Good afternoon. My name is Usama Boles. I am a consultant cardiologist and electrophysiologist. Electrophysiology is a specialty in cardiology that deals with cardiac rhythm abnormalities, I mean heart rate or rhythm. Also, it deals with various types of intracardiac devices like pacemaker or defibrillators, as well as it deals with a risk of sudden cardiac death and the interventional options of ablations. I am actually trained in the Irish system here in the Royal College of Physicians of Ireland, where I got my specialist training. Then I further advanced my training by certain centers in England, in Southampton, Royal Free, and Norwich University Hospital, before I go for my advanced fellowship training in arrhythmia specialty in Canada and Queen's University in Ontario for 2 years, before I come back again to start as a consultant cardiac electrophysiologist and cardiologist, of course, from July 2017 in the Mater in Dublin. So it is my pleasure to be with you today to present a talk about arrhythmia, which means abnormal heartbeats and its relation to higher stroke burden, especially in the community, if it goes unnoticed or if the wrong expertise or the correct expertise is not thought at the correct time. If you may allow me just to give you an overview about arrhythmia. So this is most common is atrial fibrillation, which is irregular heartbeats. I'm sure that you are familiar with this. Some of your friends or colleagues or family members who had a presentation with a stroke and found to have irregular heartbeats. It is around 11% in our community and above the age of 65. But if you would imagine that by the year of 2046, according to our Central European stats in Ireland here, our atrial fibrillation patients will be around 22% to 27% or 28%. That's quite high in the community, meaning that every 3 people are at high risk of having irregular heartbeats. We call it atrial fibrillation, and then at risk of having stroke. Now, we know by and large, these are the different types of arrhythmias. So arrhythmias around 26, 27 types of them. And that's why it has a very advanced subspecialty of interest in training in cardiology. And we have to know that fast heartbeats, which you call it AVNRT, it's very common, around 60 to 70% of them all. We have looked at first presentation with a stroke in our hospital. And interestingly, when we audited that, we found actually 19% of patients presenting first time with a stroke having atrial fibrillation. And one of our stroke physicians, he has done a very comprehensive audit, and he looked at 1 year audit of those people presenting with a stroke and 156 patients. We found 41% of them with irregular heartbeats and they called atrial fibrillation, and 18% are just new diagnosed atrial fibrillation. Unfortunately, wasn't picked up before, and unfortunately, they didn't receive the correct blood thinner before. And most importantly, a lot of them actually were already known atrial fibrillation, but they were on the wrong dosing of medication. That's why we always recommend you have to see a cardiologist at least, or advanced cardiac electrophysiologist if you have an access to. And this, the knowledge before and after lecture. I hope I didn't bore you that much. Anyway, let's talk about stroke. As we talked about, 1 every 3 will lifetime have an evidence of or a risk of having stroke above the age of 55. And it is more common in males and projected to be very high by the age of 2060. And lifetime of stroke or atrial fibrillation related stroke is increasing by age. But we have to say atrial fibrillation is the most common by and large. And we have to appreciate that older age, different ethnicities, male sex, and genetics are more components. So ideally, if you can suspect someone in the family members who has irregular heartbeats, now we were talking about the genetic components, we isolated more than 100 and 110 genes so far since 2018, very proactive area. So we know that by definition that genetics can play an important role. Insanity, unfortunately, Ireland is one of the high-risk nations of irregular heartbeats. And then you can talk about the other factors: high blood pressure, diabetes, kidney disease, and COPD, and obstructive sleep, like snoring at night with interrupted sleep, obesity, of course, smoking, heart failure, coronary artery disease. You will find the disease is very fragile to happen with all of that. That's why screening is very must in any condition of what you have seen here in this busy slide. Now, why intervention made easy? Because intervention with atrial fibrillation, and when you seek help by electrophysiologists, you have a definite way of treatment, either fully anticoagulated, protected against stroke, or you have interventional option, or you have medical option to prevent recurrence of irregular heartbeats as much as we can. It is very low complication rate. It has nowadays a very short procedure time. So it is no longer a complex procedure as it was the case 10, 15 years ago. And it reduced the risk of stroke by big time. And the most importantly, it improved the quality of life once you are back again to normal rhythm. But not only that, the heart health will improve a lot. So the longer you stay out of rhythm, the higher chance you have a stroke, the higher chance you have heart failure, the higher chance you have a recurrent hospital admissions, the higher chance, unfortunately, you have a valve leaking because the valve gets spaced out by dilated upper chambers of the heart, stretching the valve away from each other. Now, let me show you some innovations and that's a mapping system. This is a left atrium, and you see the wavefront that we collect in the cath lab, and you see how elegant, and you see the red spot here. That's the area where the arrhythmia is starting from. And interestingly, just the first or second ablation, or simply as we call it, cauterization, the superficial inner layer of the heart, terminated this arrhythmia back again to normal. So it was quite very simple, straightforward, just 10 minutes procedure. I have to show you another example of how elegant is the mapping system. And you see the droplet is passing through this area of the neck. And once you create one or two spots of ablation, this is to render this patient into normal rhythm. Again, this is a left atrium where you see the appendage here, veins, 2 on the left and the 2 on the right. And that's the back of the left atrium where the veins are and where we always end by doing the ablation. And this is a revolutionary way of doing ablation nowadays. That's what we call it, pulse field ablation. Forgive me for the terminology, but this ablation technique rendered the ablation time only 15 minutes to 20 minutes. In the past, we used to spend 2 hours doing ablation. So 20 minutes in the hand of the trained electrophysiologist or qualified electrophysiologist used to be 2 hours just not long ago. And so what we do here, actually, we put the catheter as you see it here. That's how does it look in X-ray. And we put the catheter around the vein where is the bad signals of irregular heartbeats coming from into the heart. And we give 5 pulses. And those 5 pulses takes only 2 seconds. And you see the atrial fibrillation wave, the irregular, fast, irregular heart waves here becomes pristine, normal. So that's how simple is this procedure. Complication rate is almost negligible. Again, we talk about high power, short duration, where we use the catheter point by point to encircle around those veins to prevent those bad signals to room into the heart. That's another way. And this, because it's very high power and a very short duration, again, makes the procedure time very short. I would say within an hour, you can finish with this one. And this is type of procedures when we did audit. And this is a different types of ablations. But this is not the most important. What we have seen out of those 180 cases, only 2 cases of self-limiting tamponade. Tamponade means fluids around the heart happened, probably a small leak in the wall of the heart led to this, but that delayed the discharge, no need for surgery or anything. But again, this is the most common complication we have seen, but we haven't seen anything wrong up in the 188 different or 187 other patients. So the procedure is extremely safe nowadays. Now, that's a standard electrophysiology study if we talk about different type of arrhythmia. And if you remember from my first slide when we were talking about very fast heartbeats, and that's AVNRT, that's very common in younger people. And these are born with a pre-entry circuit here in this area. So that's a heart shadow, as you see it. And these are the catheters inside the heart, 4 catheters. That's a different type of procedure. And again, done by electrophysiologist or arrhythmia specialist. And here the catheters in 4 chambers of the heart. And this is the signals that we see in the cath lab. And when we interrogate that, and this is the different areas in the heart. That's a different type of arrhythmia, as well as we call it atrial flutter. That's on the right side. That's a third type, different from the other 2. And as you see the waves, and this is the tricuspid valve on the right side. That's the vena cava inferior, where all the blood from the lower part of the body goes into inside the heart. And what we create, actually, we create a line of block. You see the waves are propagating around this valve. Yeah, so we create the line of block here. We ablate this line only, and it blocks the waves. And then we get rid of this atrial flutter. And that's a different way of how to see this flutter, either clockwise or counterclockwise. It doesn't really matter so much, but it is all dependent on this region. So we ablate this region only. Just a few points of spot. That takes around 15 minutes in the cath lab. But again, another example of not only ablations, but if you may allow me, I would like to share with you a very interesting and unique technique of pacing. That's what we call it left bundle pacing. The conventional pacing usually can lead to heart failure if the patient is very reliable on the pacemaker. And hence, we are most predominantly offering this new pacemaker type. And we are in the region here, probably one of the few centers in the whole country that capable to do this new procedure, to have a synchronized type of pacemaker. So here, for example, I'll show you this heart before the pacemaker. You see how poor is the ventricle moving here. You see how lazy is the movement. You see the contractions of the wall. It's just jittery septum and the lateral wall. The ventricle is almost almost not moving. And when we look at the cross-sectional from the top, you see very poor movement, and the function of the heart of this patient is very poor. But now look after what we have done with the new pace. And this is a live case was just a few weeks ago. And look now, look how the contraction has much improved here. And look at how was it here. You see there, very poor. But look at it here now. Very strong contraction. And this is the lead that when we paste it from here. So what we usually do in this case, we go from the right side as usual, and we screw the lead all the way through. You see the arrow here until start to pace from this side. And once it started to pace from this side, the whole main chamber, which is the left ventricle, the kicking chamber, the chamber that gives you the blood pressure of 120/80, is very strong and coherent. And look at here, when we looked at the cross-sectional, the same patient. But you see the wall, how much is contracting now, while here, how much was poorly contracting. It's almost not contracting at all. But look how much it is improved here. You see, the walls almost kissing each other. What I want to say, this new technology has made our life much better in the cath lab, and have made the outcome of the patients with heart failure much improved. And hence we recommend it. And there is a different, old conventional way, we call it CRT, cardiac resynchronization. We used to go from outside the heart to the left side and trying to pace from there. But this is much faster, easier, and quite safe. And most importantly, the lead has a higher stability. Now, let me share with you actually the international figures of ablation, for example, a success rate. You see it is quite high. This is different type of arrhythmias. And here are the complication rate, maximum 1.5%. So we talk really about very easy, very robust technology that we have, and we are pleased to have it in Whitfield as one of the few centers in the country especially when it comes to atrial fibrillation and left bundle pacing. It is not available everywhere in the country, but we are way ahead of the game. So many big centers, and that is the aim, and the target is to offer this interventional, easy intervention to as many patients as we can, to minimize the risk of arrhythmia, minimize the risk of heart failure, hospital admission, and most importantly, reduce the risk of almost 41% of arrhythmia with those. Thank you so much.